And is all of this done like on TV? Like the imager is watching a TV screen, or is he looking at what he's studying?
No, you're actually looking at images on the screen, on a TV, on a monitor.
Okay.
Yeah.
And is the patient allowed to watch too?
No, well, the patient's in the scanner when they're being scanned. We're not quite to the point where it's Dr.
Okay.
Spock with the wand and you can watch.
So you can't like look at the corner and see your pictures?
No.
Okay. So the new equipment, what are some of the new testing things that we're doing?
Well, one new area that we're going to bring on board in the short term here is breast MRI. With adding a second MRI scanner now in the system gives us the capability and the high upgrade in the machine to be able to do breast MRI for the first time in Hallmark.
And how do you know, I mean, this may be another whole hour, but maybe you can give me a short answer. How do you know whether a person needs a mammogram, an ultrasound, an MRI, a this or that?
Right, right. Well, the standard modalities, digital mammography, is staying the standard for breast screening for everyone. And as you know, if there is a problem with a digital mammogram or something's unclear, we have a toolkit that we kind of use. One of those tools is ultrasound. We're adding breast MRI to that toolkit. So you may come in for a screening mammogram and have a question raised, and your radiologist may use ultrasound or breast MRI to clarify the situation to know.
So what would you see differently on a CT than an MRI? Because they're both, I mean, I'm in the dark ages here.
Yeah.
Bones are on an X-ray.
Yes.
Soft tissue is on a CT and MRI. So how would you?
Well, the MRI is different in that it allows, a breast MRI is done while giving gadolinium. And they've found, fortuitously, that some problems in the breast respond to gadolinium in a particular way.
So and gadolinium is like an IV
It's like
medication.
an IV, yes, an IV medication.
And it goes to the breast?
Goes through your whole system, but it particularly reacts with certain types of breast tissue patterns in a particular way so you can make an earlier diagnosis of breast cancer and at times other benign lesions. So it does definitely add to the diagnostic toolkit. Breast MRI is used, one category is that toolbox type look, the problem solver. Breast MRI is also used if you have an established diagnosis of cancer. Now, breast MRI is a tool that's being more and more frequently used to, say, follow up someone with breast cancer, or before surgery or chemotherapy to actually determine the extent of the cancer so that you know exactly what you're dealing with ahead of time, so those specialists that take care of you, the surgeon and the oncologists and the radiotherapists, know exactly what you have. It aids greatly in that way.
Is it used to check out whether there's lymph node involvement, like in a breast cancer?
Yeah, it doesn't particularly look at the lymph nodes. What it can do, and a lot of what it's doing is it's really coming on the forefront now, so a lot of this still has to be worked out, but it really can find extent. In other words, it can find a second lesion in the same breast that might change the approach, or it can find bilateral disease that can change the approach. So all that just factors into improved care.
And to the plan of treatment.
That's right, yeah.
This is sort of a side question. Is it true that if you have breast cancer in one breast, it's more likely to occur in the other?
Yes. Yeah. Unfortunately, your lifetime risk of developing breast cancer as a woman is about 8 to 10%. And if you have an initial breast cancer, your risk for the other breast is increased. So that's why these women then get enhanced surveillance going forward.
So that they move into a higher risk group.
Move into the higher risk group, and you have improved surveillance to try to detect any new issue should it appear as quickly as possible.
Okay. And breast MRI is brand new? How long has it been?
It's not brand new. It's been around in one variety or another for about 10 years, but it's really just coming on the forefront now for kind of 3 reasons. One is the equipment has just gotten better, so the definition is clearer. Number 2 is, we have a whole bunch of knowledge about breast disease out there from millions of mammograms that have been done and lots of surgery. It wasn't until really they kind of standardized how breast MRI is reported, and then also the industry moved to more standardized types of ways to scan the breast, that we got some good data in that showed it really made a significant difference. And then lastly, it's relatively recent in the community that we're able to actually do a breast biopsy in the MRI environment. So you may end up with, if you had a normal mammogram, a normal ultrasound, were a high-risk patient and had an issue on your breast MRI, before you could biopsy in the MRI environment, you were in a tough spot.
So in other words, they could not see the cancer except on MRI.
That's correct.
And with just MRI, you couldn't then say, oh, right there, 2 inches to the left and 1 inch forward. It wasn't that easy until it was attached.
That's right. I mean, that's what they tried to do, would be to say it was in a particular quadrant. But now we're at a different level of sophistication. If you have a breast MRI and an abnormality, it can be biopsied percutaneously through the skin with a nick about that big during the MRI. So it really has taken a great leap forward in terms of breast care, yeah.
Huge change.
It's good stuff, yes. It's very good for the patients.
And it's weekly, monthly. Yeah, I mean, it feels like before you spin around twice, there's brand new equipment and new tests that you can do.
Yep. It's an exciting field.
It is.
It really is, to be in a field all this time and have, I'm like a, there's always something new. It's an
New
exciting.
toys.
That's right. That's
For the
exactly
doctors.
right. That's exactly right.
Well,
Good for the patients, though, too.
Yes. Well, the other thing that's amazing is, you go to medical school in 1960 or 1980, whenever, and then I've heard radiologists say that everything you learned is no longer current. It's like you have to learn everything new.
Right.
That's not true with other specialties. They get refined, but with the equipment issue here,
Yeah, I think it is, though. I think.
throw out everything you used to know. Like they used to do arthroscopic exams. Now they don't do that. They do.
Right. Well, it changes. It morphs. And it's a development, and that's what makes it an exciting field, quite frankly. That's what keeps the interest going. Something new all the time.
And better and better ways to find things earlier and earlier.
Yep.
So other than, well, before we leave the breast area, who should get this done and who should get everybody should have a mammogram. But then who are the high-risk people, the ones you mentioned who've had one cancer?
Well,
who else?
The definition of high risk is it's sophisticated, and it really should come in conjunction with your primary care physician. But certainly there are some things that really stand out as being hallmarks of a high-risk situation. Probably the largest is if you are known to have a genetic, it's quite frankly a gene mutation that lends itself to a higher risk for breast cancer and ovarian cancer. They're known as BRCA1 and 2. So that there are those.
BRCA1 and BRCA2.
Yeah, there's those people that unfortunately have that, but thank goodness they know about it.
How would you know about it? You would first get your mammogram news.
No. Well,
Wouldn't you? Because you don't just go off to your doctor and say, I think I'll have a BRCA1 test.
Well, now we're getting into how you define high risk. So you would. This is an area that really there are specialists that do this, and it's highly advisable to talk to them about it. But I guess the core question for us, Lynn, is how do you get to that specialist? So you can think of saying, well, do I have several relatives, several SIBs or a mom and a SIB that have breast cancer? Was that breast cancer, did it show up at an early age, less than 50? Okay.
Before menopause.
Yep. Did somebody in the family have breast cancer and ovarian cancer? Okay. So there are things that kind of clue us into saying, gee, you know what, maybe there's a pattern here. I'll talk to my primary care or my GYN doc, and they'll get me to the right person. Because not every single one of those scenarios means that you have a genetic predisposition. Often it's kind of just an overriding of sporadic cases, but that's where that specialist needs to come in to know exactly what to do and explain it all ahead of time.